consultant neurology in Aster Ramesh Hospital to come on to the dais and moderate this session.
I take immense pleasure in inviting Dr. Sivaramakrishna, CH, consultant neurologist, Guntur City Hospital, to come on to the dais.
We are honored to invite Dr. Madhuri Kumari, consultant neurologist in Vijayawada, to come on to the dais and moderate this session.
Now we are delighted to invite Dr. Ramana Reddy Garu, Vijaya Super Speciality Hospital, Vijayawada, to come on to the dais.
We are honored to welcome Dr. Himabindu B, consultant neurologist in Shrestha Hospitals, Guntur, as a panelist onto the dais.
చిన్నగా రాదా వేరే ల్యాప్టాప్ కన్నా మొత్తం కట్ అయినట్టుంది కాదు కరెక్టే ఉంటుంది. ఒక్క నిమిషం ఇది ఒకసారి ఎస్కేప్ చేస్తాను. ఒక్క నిమిషం ఇది ఫుల్గా రాలేదనుకుంటా. సరే ఓకే చెప్పేస్తాను.
After this session, they're planning a quiz, so I request all the residents and DNB stay back after the session 7. Thank you.
Good afternoon all. Today, this is the last session, and I am Dr. Anil, neuro resident, Ramesh Hospital. Today I am going to discuss two cases. The first case is curious case of fatigue, which is landed in crisis. The history begins like this. This is a history of a 65 years old male who was presented with sore throat and cough, and also shortness of breath. It was associated with generalized weakness. So for this, the patient received paracetamol, montelukast, and levocetirizine, and azithromycin. And the sore throat improved. Despite this, the patient continues to have cough after eating, and there is shortness of breath while doing daily course. History continued, and 3 days later, he was brought to emergency with acute worsening of shortness of breath, and he was evaluated in ER. The patient was found to have aspiration pneumonia. He was intubated and mechanically ventilated in view of hypoxia. And then the patient was started on IV antibiotics. And 2 days after admission, the patient was clinically better, but he was obeying command, and he was referred to neurologist in view of difficulty in weaning off from the ventilator. And upon examination by the neurologist, the patient history was reviewed, and the patient history he is having the history of fatigue, which was worsening as the day progressed for the past 3 months, which was improving with rest, and he is also having occasional difficulty in swallowing, mostly for liquids and then solids, and he is also having nasal regurgitation. On examination, there was right eye ptosis was observed, which is fluctuating, and there was proximal upper and lower limb weakness was noted. So points worth noting here is the fluctuating fatigue, which was present for 3 months, and he was having occasional dysphagia, which was for liquids, and history of intercurrent infections and use of macrolide antibiotics. So with this, we kept the differentials as Guillain-Barré syndrome, myasthenia gravis crisis, and critical illness neuropathy. And we have done RNS, that is repeated nerve stimulation, which showed decremental response. We can see here, decremental response is observed. And after that, initial workup, we have given the patient neostigmine with glycopyrrolate, which was given for challenge, and the ptosis and power was improved. And here, the provisional diagnosis of myasthenia gravis was done, and the patient was in crisis, was identified. We have given IV immunoglobulin, started at 0.4 milligrams per kg with thromboprophylaxis with enoxaparin, and neostigmine with glycopyrrolate was given during the hospital stay. And we have sent for anticholinesterase antibodies, which are mild positive, and muscarinic antibodies were negative. The patient was discharged on pyridostigmine plus low-dose steroids at 0.5 milligrams per kg. And the patient was offered rituximab. So I request Prashant Gar to continue the session. Thank you.
A small technical problem is there. We'll change the PPT. There is small technical problem with the fonts. I request your insights into managing this case if in a resource limited setting. If IVAs is not possible, what are the possibilities to manage this case?
Like in any clinical neurology, most important aspect is history. So many times in myasthenia, on examination the findings may be subtle. So if you take a very proper history about myasthenic weakness, and many times patients may not typically present with ocular and then bulbar and then, so like this case presented more like respiratory, and after when the patient is not able to wean off ventilator, patient was diagnosed with myasthenia. So IVIG, like when we are residents, I don't think we have used IVIG. So there sometimes the patient may respond with steroid or even plasmapheresis. And nowadays we are using IVIG with ease, and anyhow symptomatic treatment with pyridostigmine. So and follow up with depending on patient may go for the thymectomy or any immunosuppressants like azathioprine or whatever the particular in that particular institute you follow. Any comments from
And this patient actually is a old physician, sir. Actually, sons also doctors, they used initially the antibiotics and themselves, and then actually when came to hospital, we diagnosed to have myasthenia. Actually.
In acute management of myasthenia gravis, the treatment of choice is particularly when the patient is in crisis, is IV immunoglobulins. If they are not available, suppose, or patient is not affordable for IG immunoglobulins, next choice is plasmapheresis. So you should go for a plasmapheresis.
Any role in...
If the patient is still not affordable for a plasmapheresis, as we see in Indian setup, a lot of group of patients not affordable for immunoglobulins and also plasmapheresis, we will go for steroids. Steroids with antibiotics and supportive management. That is only a treatment option in majority of the patients who presented in myasthenic crisis in India.
Yes.
But if the patient is having insurance and highly affordable, IV immunoglobulins or plasmapheresis. But preferred treatment is immunoglobulins because of less side effects.
Yes, sir.
What is his age?
73.
73 years. Plasmapheresis is unlikely because of associated cardiac complications and many things will be there.
Mike.
We have given cyclophosphamide for 2 patients in impending crisis. Not exactly in crisis, but in impending crisis, cyclophosphamide we have given. Both the patients were recovered well. And after that, we have increased the dose of pyridostigmine. That is 60 mg TID plus 180 mg SR. Also we tried. Then the patients are comfortable and we discharged them.
Little information on myasthenia crisis. It's defined as a worsening of myasthenia weakness.
One small clinical point: when somebody is on ventilator with myasthenic crisis, the main problem will be whether it is a myasthenic crisis or a cholinergic crisis.
Yes.
So what do you do in those situations?
Yes, sir. Like I'll give information on this, sir. Which myasthenia crisis is defined as a worsening of myasthenic weakness, which requires intubation either mechanical or invasive. Is sometimes up to 20% of the cases it may be the first presentation of myasthenia gravis. Like when a patient with a difficult weaning, we should always think about myasthenia. As Sar is telling, paradoxal weakness with the anticholinesterase medication is also can present similar symptoms. It is called cholinergic crisis. So risk factors for myasthenia crisis include late onset of myasthenia, as in this case, presence of MuSK antibodies and presence of thymoma and greater disease severity at the diagnosis. And usually it is more within the first 2 to 3 years of the diagnosis. Precipitating factors, concurrent infection as we see in this case, and any major surgery or a surgical intervention or following a neuromuscular blockade anesthesia, some myasthenia crisis can precipitate, and pregnancy also can precipitate myasthenia crisis. So common medications that can cause myasthenia crisis is like important point is magnesium that is given in pregnancy for any eclampsia can precipitate. Beta blockers also common agents many people use also can precipitate. And antibiotics, fluoroquinolones, macrolides, aminoglycosides, these are commonly used for respiratory illnesses. These can precipitate myasthenia crisis. And many surprise statin also can cause myasthenia crisis. We should be careful in dealing any patient, any weakness, fatigable weakness, any even fatigue also we should suspect myasthenia, and then we should be careful in giving medication, unnecessary medications. Mortality also is high, up to 10% mortality can be there in myasthenia crisis. So management is like IVIG with high dose glucocorticoids post crisis management. The cholinergic crisis, it's a paradoxical weakness of, with the anticholinesterase medications. It results from the overstimulation of the nicotinic and muscarinic receptors. Causes include high dose of and acetylcholinesterase inhibitors, and then as we know, pesticides and insecticide poisoning, OP poisoning also can precipitate cholinergic crisis. So then how do you, so what is the, in myasthenia patients, like how much dose can precipitate cholinergic crisis? Like a very high dose, like 120 mg every 3 hours. That is almost like more than, almost like more than 2,000 grams a day can precipitate myasthenia crisis. Classical symptoms of myasthenia crisis, cholinergic crisis include sludge, salivation, lacrimation, urinary frequency, diarrhea, or GI cramping. So one crude test, I say crude test because it will worsen the symptoms in cholinergic crisis, heterofonium test. It will improve symptoms in myasthenia, whereas it will worsen symptom in cholinergic crisis. It has to be done in ICU setting. We have to resuscitate the patient. So it is like a little crude method to identify if you don't know the history properly. And treatment is like what we treat for OP poisoning, atropine and palm we give. The take-home message from this case is like fatigue, ignored by many people is a telltale symptom for the evolving MG. Unexpected weakness, dysphagia to liquids. Any neurological dysphagia will present with difficulty for the liquids. That is more important thing. And judicious use of antibiotics is also a very important thing. And difficulty in weaning off from a ventilator should raise the suspicion towards a neuromuscular junction disorder. Thank you. We'll go to next case. Okay. Okay, sir. Okay. Okay, sir. We're going to present next case.
Thank you. Coming to the next presentation, this is regarding connecting crippling dots regarding NMOSD, that is neuromyelitis optica spectrum disorders. So the case is presenting like this: 23-year-old female who is antenatal primary gravida 5th month amenorrhea. She came with history of blurring of vision in both eyes, which is more in right eye than left for the past 3 months, and there was also history of weakness of bilateral lower limbs for 2 weeks. So for this, the history of blurring of vision is both eyes are present. Right eye is more than left eye. It is present for past 3 months. For this, she visited a local optometrist, taken spectacles. In spite of this one, the blurring of vision progressed over the next few months. And the history of weakness of lower limbs, it was present in the form of difficulty in walking for the first 2 weeks. And there was also stiffness of both lower limbs, which was associated with weakness of right upper limb, and there was decreased in hand grip. There was also mild facial deviation, and there were no bowel bladder involvement. The history of past illness, it was nearly significant, no significant things are there. And coming to neurological examination, relative apparent pupillary defect was present in both eyes, and there was a right upper motor neuron facial palsy. On power examination, it was decreased in both lower limbs. It is 2 in right and 3 in left, and there is a mild decrease of power in right upper limb. It was 4 minus by 5. And coming to reflexes, they were normal, except there was a clonus, right angle clonus was there. This is the MRI images of the patient. We can see the diffusion restriction in the left optic nerve. This is T2 hyperintensity, we can see in right optic nerve, as well as this is the SAG image of right optic nerve. Intensities can be seen here. This is the T2 flare. We can see the hyperintensities which are present in parietal, occipital and bilateral frontal regions can be seen here, which is suggestive of some demyelinating lesions. This is T1, which is showing hyperintensities in the same areas where we have previously seen hyperintensities in the frontal, parietal as well as occipital regions. And this is the spine sagittal section, where no significant lesions are seen here. On exam and testing for blood, anti-aquaporin 4 antibodies were strongly positive for this patient, and we have done visual evoked potential, which we can observe that they are prolonged in both eyes. Right was more prolonged, and she was given treatment with IV methylprednisolone for 5 days. The patient was clinically improved. Vision was improved by 80% in the left eye, and power improved by 80%. The patient was given rituximab 2 days after delivery in May 2024. Thank you.
Actually, I don't know about the presentation. You mentioned visual loss in 3 months and weakness in 2 weeks. Do you think there are 2 episodes or same disease progression?
Same disease progression, sir.
No, because in NMOSD or any of these demyelination condition, the characteristic symptom progresses few hours to maybe a month. Rarely it progresses for more than 1 month. Actually, it's a red flag for demyelination if it progresses for 1 month. So probably this patient must have had initially bilateral optic neuropathy or optic neuritis, and she had a recurrent episode with probably cerebral cause for his paraparesis and facial. So it comes like a recurrent rather than monophasic illness.
Okay, sir.
You have done a vitamin B12 in this case?
Vitamin B not done, sir, because patient is we not done, sir.
That's one important investigation, because over 3 months history is giving, maybe 2 different episodes.
Okay, sir.
How was the contrast MRI in this patient? Probably that would
Contrast
have
was not
thrown
done.
light.
Actually, patient was financial constraints have not done contrast. So whatever we sent Nieman's test for that.
Because contrast could have thrown some more light
Yes,
regarding
yeah,
the, as we were talking about the onset of the illness.
So next talk is on NMOSD, which sir will deal in great detail about the NMOSD.
There is an expert talk on white patches that darken vision by Dr. Buchiraju.
Good evening, everybody. I think we are in the fag end of this today's CME. I thank my colleague Dr. Kumar Velu and Astor Ramesh for asking me to speak on probably these demyelinating disorders which are quite recently described since last 2 decades. As such, sometimes we initially, probably a decade ago, we presented one patient, one young child, as Wernicke's encephalopathy. Actually, radiologist has described it as a Wernicke's encephalopathy in a young child of around 8 years. Actually, it is a area postrema syndrome. Probably during that time we were not so much well aware of this NMO spectrum disorders. Actually, recently also in 24, similar case reports have been described in Journal of Neurology. So many of us, these are relatively new syndromes, NMO spectrum disorder and MOGAD, or myelin oligodendrocytic protein associated disorder. So the diagnostic criteria have been evolved, even though many people thought this is some form of multiple sclerosis when the initial opticospinal, when Devick described more than a century ago about optic nerve and spinal cord involvement, and they thought it could be a Asian or a atypical form of multiple sclerosis, but we now know most of these could be due to astrocytopathy secondary to aquaporin 4 disorders, which was quite described initially in Mayo Clinic 2 decades ago. But the international panel has given that criteria just recently as 2014. So actually, even though we, as a neurologist from our residency days, we discuss more about multiple sclerosis, but we have to, most of the clinicians or even the students have to remember multiple sclerosis is not so common. I have seen nearly 6 cases of NMOSD and MOGAD last 6 months. I haven't seen a new case of MS. So this is a recent case, last case which I saw, a young, just now we had a discussion about bilateral papillitis in the IAH section. You should also remember when somebody came to you with acute onset of bilateral papilledema with some perimacular disc hemorrhages, you should suspect MOGAD or NMS disorder. This young girl presented with acute onset of visual loss for 2 weeks, for a week. Actually, she was staying in Hyderabad, and she was initially diagnosed 1 year ago for IAH on treatment, improved, and people thought this could be IAH, but she came back with some periretinal hemorrhages, and our neurology colleague has done this NMO spectrum disorder panel, which included both, and she turned out to be MOG positive. And she improved very well with IV methylprednisolone and plasmapheresis, and she was on follow-up. She improved very well, and this was actually a response, significant response to optic neuritis to steroid is much more better seen with MOGAD when compared to NMOSD. So I have both my students, Aruna and Madhavi. This is our experience at Andhra Medical College when we presented this in one of the state conferences in 21, decennial experience. It's a retrospective. We had around 65 patients, and like NMSD, 75% are females and 25% are males. And most of these patients are in the 3rd decade or 4th decade, and nearly 2/3 had NMSD positive. Because this was done in our setting, at that time the MOG panel was not done, so probably some of these seronegative for aquaporin could be MOG positive. And so most of these patients presented to us with optic neuritis, visual loss, and some patient initially, and other group presented mostly with longitudinal extent transverse myelitis. The other important feature in NMOSD is associated with other collagen vascular disease, especially patients who had recurrent episodes had more chance of having a collagen vascular disease. One patient we had also had a cerebral venous thrombosis. And most of initially we treated them with azathioprine or mycophenolate, but all the recent patients were 21 patients we treated with rituximab, only 2 had relapses. So rituximab was found to be very useful in preventing relapses. Actually, initially when NMOSD was described, many people thought it is a monophasic illness, but now we know most of the NMOSDs have relapses. Unlike multiple sclerosis, these have relapses with single episode, not secondary progressive like in MS. So we presented this in our Journal of NTR University of Health Sciences in 2018, the initial patients, and 40% had recurrence, and most of the patients who had recurrence as aquaporin 4 positive and very high mortality in this recurrent group. And most of these patients have associated autoimmune disorders. So to prevent relapse, we need to have aggressive immunotherapy with rituximab, or nowadays we have many studies have shown that newer treatments like against CD19, complement C9 and IL-6/7, FDA has approved other new drugs for immunomodulation in NMOSD disorders. So just to highlight the criteria for NMOSD, we had 6 core clinical features, which are bilateral optic neuritis, longitudinal extent transverse myelitis, area post-trema syndrome, or diencephalonic syndrome who present with narcolepsy, and any brainstem or cerebral syndrome. So if you have one core clinical feature with aquaporin 4 positivity and exclude other conditions, a typical MRI, these patients can be labeled as NMOSD. If the patient is aquaporin negative and MOG negative, like what we call double negative, if they have a typical 2 core clinical features, then this patient can be treated as NMOSD. So this is a typical picture for NMOSD, like bilateral optic neuritis on MRI orbits, and longitudinal extent means 3 vertebral segment involvement of the spinal cord. Coming to myelin MOGAD, or myelin oligodendrocytic glycoprotein, which is a cell surface protein antibody. This is a MOG-associated disorder. This criteria was given quite recently, only just 2-3 years ago. If the patient had either acute onset or acute or subacute onset bilateral optic neuritis, acute or subacute myelitis, edema presentation typically in children, and cerebral mono or polydeficits or cerebral cortical encephalitis. Any of these associated with MOG IgG positive or MRI features typical of MOGAD. If all these 3 are there, then we can label this patient as MOG associated disorder. So this is the typical differences between all the 3 primary CNS demyelinating disorder like aquaporin 4 and NMOSD, MOGAD, and multiple sclerosis. One typical feature in terms of age distribution, MOGAD can present in children, even though NMOSD and multiple sclerosis can also occur in children, but MOG can present in very early age group. That is one difference feature. And onset of age below 8 years is much more common with MOGAD when compared to NMOSD or MS. And just highlighted in our series, in NMOSD, aquaporin 4, the female to male ratio is 9:1. So it's more common in females. Even in multiple sclerosis, it's slightly more common in females, but in MOGAD, a MOG-associated disorder, it's nearly male and female are quite equal. Then other important feature is disease course. Usually NMOSD and multiple sclerosis can have relapsing. MOG is less, usually relapses are quite less with MOGAD. And coming to the clinical features, in MOG and aquaporin 4, the optic nerve involvement is usually bilateral, whereas in multiple sclerosis it is usually unilateral, and it's not so severe in response to steroid is quite good. And the other typical feature in NMOSD is the area post-trema or diencephalonic syndrome, which are quite rare in MOGAD or even in multiple sclerosis. Coming to CSF findings, oligochromal bands are positive in MS, and they are not routinely seen in NMOSD or MOG. So MOG diagnosis, if you have a core clinical feature plus aquaporin 4 positive, then it is aquaporin positive NMOSD, or if it is MOG positive with clinical syndrome, typical syndrome is MOG. So how do you differentiate, other than the clinical presentation, the radiology? For example, if you look at the optic nerve involvement, in NMOSD, the optic nerve is bilateral optic nerve involvement and longitudinal extent, mostly in the posterior part. involving the chiasma. So if you have a contrast MRI, chiasma can be highlighted posterior. So as you see in the top one, where posterior and chiasmal involvement is common with NMOSD, and the response to steroid is not so good when compared to MOG. In MOG, usually it's bilateral longitudinal extent optic neuritis, and usually is in the anterior bilateral optic nerve with on contrast they have perineural involvement, which is very characteristic of MOGAD. So if somebody presents you with acute visual loss with some pain on eye movement, you should either suspect these two, and most of the time if you do a proper MRI orbits, you can diagnose with positive on cell-based assay, either of them, and you can easily diagnose them. Whereas in MS, as I already mentioned, mostly it's very partial involvement and unilateral involvement, and so sometimes the optic nerve may not show anything except for the afferent pupillary defect. So coming to the spinal cord involvement, and it can again differentiate, like in aquaporin, NMOSD or MOGAD, it's again longitudinal extent transverse myelitis, what we call LETM, with involvement of more than three segments, usually in the cervical or cervical dorsal. Whereas in MS, it's patchy, usually the peripheral part of the spinal cord which is involved. And the only characteristic which probably differentiate MOGAD with NMOSD is the cauda equina involvement or cornus involvement, which is very typical in MOGAD. So the presentation of the spinal cord involvement again gives us a clue to what could be the possible primary CNS demyelinating disorders. Coming to the cerebral involvement, as I already mentioned, in aquaporin you have usually the periventricular, like whether it could be area postrema syndrome or a diencephalic hypothalamic involvement. And the cerebral is not so commonly seen with NMOSD, but sometimes in few percent, maybe 4 to 5% can show up even a cerebral syndrome or CNS involvement. Whereas in MOGAD, the classical presentation is bilateral cerebellar peduncle involvement, or sometimes it looks like your Japanese encephalitis, bilateral thalamic involvement or unilateral thalamic involvement to what we call the J sign, and also the gray white matter involvement causing a cerebral syndrome or ADM-like presentation, especially in children. And the classical presentation in multiple sclerosis, usually a small plaques and mostly involving the white matters, and the typical feature of Dawson's finger, perpendicular to the corpus callosum, is a very characteristic of multiple sclerosis. And so even the MRI brain. So usually if somebody comes to you with a presentation with optic neuritis or a spine, all these patients should need a MRI. You have to screen MRI of brain and spine, and even with contrast if necessary. So on contrast, in NMOSD, usually you have mostly it involves the whole of the spinal cord or central, and it shows up on contrast called what is called a bright spotty sign. And in MOGAD, mostly it's the central gray matter which is involved. So we have what is on a cross section, what is called the H sign. And in multiple sclerosis, usually a small plaques or peripheral part of the spinal cord which is involved. And you can also see the typical brain features on MRI on contrast. So coming to the relapses in all the three primary CNS demyelinating disorders, I already mentioned that aquaporin and NMOSD, you can have quite nearly 75% to 80% can have relapses. And after each relapse, there can be some amount of progression, but usually because the response to treatment is either to immunomodulation or to the acute treatment may not be complete. So sometimes the symptoms add up in NMOSD, whereas in MOG, you get relapses are quite less, but you get relapses without, and there is quite significant good response to a steroid or plasmapheresis. So you get symptoms individually in MOGAD. Whereas in, as you all classical teaching in multiple sclerosis, it can be a secondary progressive MS or a primary progressive MS where you get initial relapses. So you have to understand most of these times it's a diagnosis by exclusion, because many times in NMOSD we have associated with collagen vascular disease in quite a good number of patients, especially in relapsing NMOSD. So if patient comes to you like acute symptom onset, like less than few hours, most probably like a vascular syndrome, we should suspect probably more of vascular rather than demyelination. If it is a chronic progressive course, more than I just mentioned, if you classical teaching in Schumacher's criteria, if any progression more than 1 month is unlikely to be demyelination. Maybe it could be a secondary demyelination or a tumor or some other disease. And any active coexisting disorder which looks like on clinical or MRI, NMSD, if they are negative for cell-based cultures, you should suspect some other conditions with secondary demyelination. If there is evidence of any peripheral involvement, especially peripheral neuropathy, we should suspect probably some other diagnosis. And if there is a persistent contrast enhancement even after 3 months, it's very unusual in NMOSD or MOG. So, and presence of CSF oligoclonal bands usually indicates MS. So how do you treat these patients? In an acute attack of NMOSD or MOG, the patients, the first line of treatment is IV methylprednisolone. In adults, we usually give 1 gram per day for 5 days. If there is a usually in MOG, they have very good response. Otherwise, we can, after methylprednisolone, if there is, especially in aquaporin, probably they won't do well. So most of these patients may do well after doing a plasmapheresis. So IV methylprednisolone plasmapheresis is the treatment of choice for acute attacks. Then coming to the treatment of relapses, especially in NMOSD disorders, we have 4 groups of drugs. Anti-CD20, that is rituximab, anti-CD19, which is inebilizumab, and anti-IL-6 cetralizumab or tocilizumab, and anti-C5 complement C5 eculizumab and ravulizumab. All these 4 drugs have FDA is approved for NMOSD. Even though rituximab doesn't have a double-blind trial, most of the other 3 drugs, so FDA has approved anti-CD9, anti-IL-6 and anti-C5 treatments. So you have now 4 groups of drugs for prevention. So out of all these, most of these are seen response in mostly in aquaporin 4 positive NMOSDs. So initially in India, probably because of the cost and availability, we mostly use rituximab in the classical dosages, so once per week for 4 weeks and followed by 6 months depending on the response. Just in recently, JNP has published from the NMOS group the different features for aquaporin positive, seronegative and MOGAD. This is a classical, as I already mentioned. MOGAD is also seen in children, and females are more common in NMOSD aquaporin positive. And most of these patients initially presented with optic neuritis and transverse myelitis. And associated autoimmune diseases are mostly seen with aquaporin 4 seropositive NMOSD. So actually here, if you see, the immunomodulatory treatment have shown prevention of relapses or reducing relapses in aquaporin 4 positive NMOSD or aquaporin negative, but as already shown, the relapses are quite less with NMOSD and independent, so there's not much difference in MOGAD. So we have very few studies in MOGAD. And recently, actually, after last, more of MOGAD is seen, and in India, probably because they're like Asian non-Caucasian population, NMOSD and MOGAD are more common than actually MS. And you see the pictogram. Initially, mostly people have used azathioprine, mycophenolate or rituximab. And nowadays, the new drugs, especially this NMOS group is from Germany and Austria. So now new drugs like cetralizumab, eculizumab and other drugs are being tried. If patient does not respond to rituximab, probably the other treatment of choice, eculizumab, if it is a seropositive, eculizumab is done most the studies have shown it as a very good response, anti-CE5, complement 5 studies. So this is just an algorithm. If somebody comes to you with a classical picture of acute optic neuritis or any of these core clinical features, if they are there and you do a NMOSD panel, whether it's MOG or aquaporin 4, if some aquaporin 4 is positive, it becomes NMOSD. If MOG positive, and typical MRI features are either of these three. For all the three core clinical features, you can label them and treat accordingly. So acute treatment is with steroids, IV methyl high dose steroids plus plasmapheresis in NMOSD and MOG, followed by, if it is NMOSD, followed by immunomodulation with rituximab or any new immunomodulatory therapy. With MOG, we don't have clear-cut answers for prophylactic immunomodulation because relapses are quite less and studies haven't shown anything significant with any of these drugs. It depends on the response to the primary, or you wait for the second episode before you give a immunomodulatory therapy for MOG. So I think last decade, this new both NMOSD and MOGAD have been quite commonly seen in Asian population when compared to multiple sclerosis. So, and we have some good studies with NMOSD with new immunomodulation. So thank you again, one and all, for the patient hearing. Thank you.
Thank you so much, sir. That's a wonderful session and an informative session. And thank you so much to all the panelists who joined for this session. Now I request Dr. Meena and Dr. Rajesh to take over the quiz session.